Okay, let's do a little healthcare briefing. 6:15. As you know, this is a topic that could take a whole college course. And it's going to be difficult to compress this into 20 minutes or so and leave time for discussion. I'm going to do the best I can. Destination single payer. I'm not even going to go through the history here except to say that after the Shell Report of 2011, the legislature enthusiastically passed Act 48, the act that sets up the machinery for single-payer health care, which will come alive in 2017, provided the federal government gives us a waiver to do it, which is not at all certain. Here are the main features of single-payer. The governor is fond of saying health care is a human right. This is frankly preposterous. There's nowhere in any constitution any right that you have to force medical providers to provide you with medical care of your choice at their expense. However, if you have money, you can contract with them to do it. But you have no right. You have a right to speech. You can get up and talk. You can't tell me I have to pay for your airtime. That's up to you. But the backers of single payer are eager to say that. Shumlin has said it repeatedly. The act itself says health care is a public good, which it also is not. A public good in the economic literature has two characteristics. One, it is non-rivalrous. That is, what I take doesn't diminish what's left for you to take. And secondly, it's non-excludable. I can't keep people from taking it. Air comes to mind. Okay, I can breathe the air, and I can't stop you from breathing the same air. Okay, those are public goods. You can say police protection is a public good for everybody that lives in the community, because the fire department and the police come for everybody's needs. But healthcare is certainly not a public good. Education is not a public good. And most anything else is not a public good. So this is a semantic trap. And I suppose it's not worth your time as a candidate to get into an argument about it. You should at least know that this is poppycock. Universal. Every Vermonter must be in. That's the principle. As we shall see, that principle will not be honored under Green Mountain Care. Centralized government control of Green Mountain Care Board. The board is a 5-member appointed board that will have complete control of everything, because the single payer people say, and so does Dr. Shao, we don't have a system. We have a whole bunch of doctors here and hospitals there and nursing homes here and chiropractors there and whatever that don't work together, and that's why we have this expensive healthcare system. And there's a scintilla of truth in that. But our solution, of course, is sort of what Joe Stalin's solution was for the Soviet Union. I'm the dictator, or Saddam Hussein, to take another current example. I can tell every hospital, I can shut down the 3 hospitals that are inefficient. That would be Gifford, Copley, and Grace Cottage or Porter. I can ship the doctors from this hospital to this hospital to meet what I believe is, and I can do whatever I want, because I'm the czar. Green Mountain Care Board is the czar. It has control of everything. And when Cynthia Browning offered an amendment to strip the board of any control over your private agreement with your doctor to provide services to you, Cash, me and you, the House voted it down on party lines, with a couple of honorable exceptions, the Democrats, because they simply believe that we can't let people slip out from underneath the system and make a private deal, because the rich will do that, and then we'll have 2-tiered health care. People with money will buy health care from providers under the table, so to speak, or off the books, while all the rest of us poor guys and gals will have to go down to the waiting line at the clinic. So the Green Mountain Care Board has to have the power to stop that transaction. Incidentally, Canadian Medicare had the same rule. Doctors in Canada are not allowed to accept payment for any service covered by Canadian Medicare under pain of fine and imprisonment. The Supreme Court of Canada in 2005 overturned that.
Some provinces just changed that, not all of them.
Well, the Canadian Supreme Court knocked it flat as a bombshell in Canada and said, you know, the Constitution gives us a right to access to health care. If you're kept waiting for 6 months, 12 months, 15 months for diagnostics or cancer treatment or diabetes follow-up, you're not getting access to health care, and we can't say to you, you can't go out and talk to your doctor about helping you. Of course, people in Canada go to Fletcher Allen and Newport and Franklin Northwestern Medical Center and all the way across the country to American hospitals if they can afford to, and the Canadians can't police it. But anyway, the court struck that down, so that's now going to open the door. In fact, Canada doctors were, to avoid this, we're offering what amounts to a Sam's Club ticket, where you can buy the ticket to the doctor's services, and the ticket authorizes you to park for free at his office. Okay? The medical services are free. It's illegal to sell medical services, but you can rent parking places. And there are doctors that actually rented out their parking places at a substantial price so they could be able to get the free medical services inside. I mean, that's how the market tries to defeat totalitarian rules. Okay? In Canada, care is free at the point of service. That is, you wave your little card, says I'm a Canadian citizen, my Medicare card, give me my service. You're still functional when you get to the head of the line. But in Vermont, it'll have an 87% actuarial value. That means for every $100 of medical services, the patient will pay, on average, 13%. Either deductible, a copay, some kind of a premium, some kind of device. What kind of device? Well, I asked Robin Lunge, I wrote her a letter, said she's the director of healthcare reform. Where are you going to get the 13%? How are you going to extract it from the patient? Because it has to be, presumably it'd have to be income sensitized somehow. She wrote me a BS letter back explaining actuarial value, which if I hadn't known, I wouldn't have sent the letter in the first place. And I wrote her back again, said, all right, let's try this again. And she wouldn't, and she gave me another answer, and finally she had her assistant call me up. I finally said, look, there's three choices. You have no idea what I'm talking about. You don't have any idea how you're going to collect the 13%, or you're going to put this all out to a contractor in a year or two and let them figure it out. And the woman that called me grudgingly admitted C was the right answer. They have no idea how they're going to do it. Now, Canada is 100% actuarial value. There's no payment by the patient with very limited exceptions. So here it's going to be 87%, which reduces the cost to the taxpayer. But somehow you've got to have a mechanism for collecting it, and they don't know what it is. And it annoys me that all these geniuses have told us they knew how to do everything 20 years ago. I had to face this in the Senate in 1992. You know, suddenly they don't seem to know how to do anything and need billions and millions of dollars from Washington to figure out what it was they were talking about. Global budget controls costs. Governor Shumlin's fond of saying that cost containment is a very important part of Green Mountain Care.
Can you explain what a global budget is for this?
I will. And if we can't control costs somehow, then of course we can't go ahead with it. That's sound, responsible thinking. The global budget is the Canadian method for controlling costs. It says the board, it's called RAMQ, R-A-M-Q in Quebec, a French acronym. The board says, Montreal Hospital, you got this much money. Sherbrooke Hospital, you got that much money. Doctors' offices, you got this much revenue limit each quarter. And so on and so on and so on, across the whole province. Okay, then they add up all those numbers and say, well, there's our global budget. Costs are contained. In fact, I had Senator Cheryl Rivers, a big advocate for this, said in response to me at one point, when I asked about cost containment, she says, well, we have global budgets, and when the providers spend up to the global budget, costs are contained. What about the people out in the waiting room? They have to wait till the next budget period to bring sandwiches and bedroll and something and wait till January 1st to start over? This global budget is a bureaucratic way of telling each unit how much they can spend according to the projections made by the experts who gave you the healthcare exchange.
So
Yes,
if I know my annual budget and is $30,000 a year, that would be, let's say, what I make as a person. I know what my costs are per month, my fixed costs, and how much I can spend extra and what I can't afford. Does this mean if a hospital, let's say, gets $3 million a year, they know what their fixed costs are and how much they're going to have to spend? Does that mean that they're obviously not going to go run away the first 3 months and run out? Does that mean all of a sudden we're going to be dispensing medicine in a type of, I just lost the word, ration system?
well, yes.
Okay.
They have to decide how to stay under the cap.
That was a rhetorical question, just wanted to make sure.
Yeah, you're quite right. And a
Not going to that
major
type,
affliction
but-
in Quebec is the closed-off wing. So the Quebec theory of cost containment runs like this. To pay a bill, the government has to receive a bill. The bill has to come from an authorized provider, a doctor, let's say, or a hospital. If there are no people authorizing bills, then nobody has to write checks. So first they clamp down on the medical schools to prevent them from graduating doctors, so there would be fewer doctors. They spent up to $500,000 to buy out doctors' practices to get them to retire, so they can't authorize any more, send in any more bills. And they closed whole wings of hospitals. So the hospital can say, hey, don't bring the patient here, everything's full. They also do what's called hotel patients. These are people who aren't intensely sick, but sort of like nursing home level people, as opposed to people who are in intensive care. If they can fill your beds up with people who are cheap to maintain, a couple trays of food a day and then aspirins, you're a lot better off than if you got somebody that's terribly sick that has all kinds of management problems. So fill your hospital up with the least expensive patients, and then have somebody out the front door says, "Not here, don't bring them here. We're full." That's what happens under global payer. And it's not hard to figure out the tricks. If you put yourself in the position of the person who's got this tub of money, and the tub of money is sinking every day as they pay the expenditures for light and heat and doctor's salaries and so on, and it's getting down low, and you've got a chart over the side saying it should be down to here by the 1st of July. If it's down to here, I got trouble. What am I going to do? Well,
Less patient care.
you think of what you're going to do, and you got lots to work with. People who used to get major morphine-based opiate pain relief are going to get aspirins. Aspirins are cheap. Okay, I don't want to dwell on this too much. Finally, payment reform, a concept I have some sympathy for. We currently have fee-for-service now because Medicare has the resource-based relative value system, RBRVS, designed by William Schau, the guy who designed this whole thing for the legislature. It puts a price tag on every discrete service offered by a doctor or a hospital. Phlebotomy, gastroenterology, whatever it is. There's a huge book of codings that it has a price attached that Medicare will pay with some adjustments. And this, of course, is an incentive to run through as many coding billings as you can run through to increase your revenue. More and more tests, for example, or MRI scans, things like that. So the system is organized in a way that was perfectly common 60 years ago, but nowadays it has become an invitation to keep doing more stuff, even though in your heart of hearts you might know that it's not doing the patient any good, but it is bringing in money. Okay, Quebec Medicare, I just mentioned that. I'll just skip over it quickly. Free at the point of service, flash your card. The doctors and hospitals are mostly private. When I asked Governor Shumlin this at a chamber breakfast in St. Johnsbury, I said, since you mentioned Quebec earlier, on some other matter, could you tell us in what material aspect does Quebec Medicare differ from your proposed Green Mountain Care? And he had that quick deer in the headlights look, but the guy's very agile, okay? And I could see him recalculating, and he said, well, in Canada, all the doctors work for the government, and here in Vermont, they'll in the hospitals, and here in Vermont, they'll remain in the private sector. I went over to the reporter and said, you know that was a colossal lie, don't you? So would you be sure to put that in tomorrow's story, so it's in writing, in the newspaper? The rest of it, private contracting forbidden, I've been across that, so I'll skip ahead of that. The results, government rationing, as you pointed out, long waiting times for treatment. The longer you wait, the longer before the billing comes in. Typically in Canada, the clinic is open from 9 to 5. 5 o'clock, your number hasn't been called. Come back tomorrow morning at 9. Very nice. People make the point that you can get a CAT scan for your dog overnight, but to get an MRI scan for your loved one may take 6 months or a year, because every time you push the scan button, it creates a billing. They don't want billings. So you have that problem, the long waiting times. The Fraser Institute in British Columbia puts out a survey every year of the waiting times by province for different kinds of services. And it's eagerly awaited in the Canadian press, because this is something that really honks off people. You know, your daughter has a sore throat and doesn't go to school. You take her down to the clinic. You take a number, you sit there and wait. Hours go by, 5 o'clock, haven't got to you. Take off tomorrow, take off from work, take your daughter out of school again, go through it all again. This is just, the Americans wouldn't stand for this. There'd be an uprising. Maddening bureaucracies. To manage everybody's health care requires lots and lots of people carrying out the politicians' orders not to go over the budget. The bureaucrats tell the providers, the actual doctors and nurses, what they can and can't do, because the bureaucrats charged with keeping the budget under control. And the doctors will say, well, it's not as medically necessary to do this, and now you're arguing with the bureaucrat. Does this sound familiar? Demoralized doctors and nurses, that's why. You will see doctors who are forbidden from giving treatment they're absolutely convinced is essential to the patient. They can't do it because some rosy-cheeked bureaucrat somewhere working out of some Dr. Shao's handbook just told them, well, you can't do that, we can't afford to do that. Obsolete technology, shabby facilities. That's because one of the options for spending your global budget is investing in facility management and maintenance. And one is to get an MRI scan, an MRI machine. Limited budget. Never mind the MRI machine. Crank up the old CAT scan again. Aggressive unionization. In the VA system, which is a government-run system like the British system, not the Canadian system, the unions are aggressive, but they can't bargain over wages because they're federal employees. Federal employees are determined by Congress. So that's off the table. In Quebec, they have some of that same thing, but very, very strong work rules unionization. If the union can't get higher wages because somebody else makes that decision, they have to make their money or build their membership by defending alleged wrongdoers in grievance proceedings and creating work rules where you have to have a member to come down and plug in the CAT scan machine who has electrical certification instead of that person taking the radiology. I mean, it's kind of foolish stuff that always goes on among construction unions, for example. New York City, you had to have an electrician plug in a power saw for a plumber, a thread machine. Honest to God, this is back in the 70s, and I couldn't believe it, but it was true. And last and not least, much higher taxation. Rob mentioned $2 billion, that's sort of the round number. Wendy Wilton did a great job in costing this thing out at a time when the administration position was that there weren't enough resources in the whole planet to be able to anybody to do this. And Wendy did it in her spare time and got it pretty much on the same money that the Avalier people did later on. $2 billion plus or minus a couple $100 million will probably be the annual tab. Green Mountain Care Board, 5-member board, full control, has power over collective bargaining. Doctors will be unionized to fight for their interests in this system. You have to wonder about a professional like a doctor also being a union member. It gives you something to think about. Power to determine the essential benefits of the Green Mountain Care Plan, as well as insurance sold on the present exchange, and the payment reform, the $45 million grant they got to figure out how to pay people for bundled services or for capitation, which are alternatives to fee-for-service. Vermont Health Connect, this is the famous, I should say notorious, healthcare exchange, created under Obamacare. We got $170 million to put this baby online. It's mandatory for small businesses under 50 employees now, and for 50 to 100 in 2016. A user can select from the Green Mountain Care approved plans, the ones they allow to be on the exchange, which may not be the one you want because only the plans approved by the board can be purchased. And you can't go to the Blue Cross and purchase the one you want because they can't sell it to you that way unless the Green Mountain Care Board says they can. Delivers income-tested tax credits to defray premium costs. This is the Obamacare subsidy program to make it affordable. What they didn't tell you exactly was that once you have a government mandated benefit, everybody wants to make sure that their service gets included in the mandated benefit. Chiropractic, for example. So every lobbyist in Washington is busy saying the essential benefit has to include my client's services. And the liberal groups, of course, demand more sweeping coverage. And so it ends up the policy you're allowed to buy is a lot more expensive than the one you were satisfied with last year. But you get premium subsidies from the government to hopefully make it within your reach. A lot of people are finding out that the higher priced policy, even with the subsidy, leaves it out of reach. The irony is all this flap we've had about the exchange goes poof in 2017 if Green Mountain Care appears. There won't be any more health insurance. Poof, all gone.
Yeah, it happens.
Okay, let me race through this. A couple of the most important points. The $580 million that Shao said would be achieved in first year savings has now completely evaporated. The administration at first said, "Ooh, what a cornucopia of loose change." After a month or two, they began to get a little bit reticent about that, and after a year, they had given up completely on saying there'll be any savings. Now they say, well, it'll flatten out the cost curve. Well, $580 million disappearing in this little state ought to be sort of, put posters up at the post office to ask what happened to it. That was if we had single payer. Single payer means everybody's in, there's one faucet that discharges money into the system. And the big gnarly hand of government is on the knob, okay? Unfortunately for that theory, there's at least 4 other payers that you're not going to get rid of that occupy about half of Vermont lives. Medicare, the federal government is simply, and the AARP and their friends are simply not going to allow Medicare to drop down to Green Mountain Care quality. What happened here? Okay, the other three are TRICARE for retired military under 65. Well, retired military generally. Large self-insured companies like ERISA companies like GE, which have their own insurance plans and will fight tooth and nail to keep from getting swept into Green Mountain Care. Shao thinks it can be done legally, but he's never seen the fury of the resistance from IBM, General Electric, and all the big companies around the country who defended ERISA furiously every time. Maryland challenged it most recently and got knocked flat. Finally, the Federal Employee Health Benefit Plan, which covers post office workers and other federal employees. So the single payer is now a half single payer. And all the alleged deficiencies you get by only having one faucet and one gnarly hand on the faucet's only got half of the flow. There are 4 other faucets over here that every hospital has to deal with different benefits, different conditions, just like insurance policies, one of which is an insurance policy. Okay, the final thing is paying for this. Rob pointed out it was $2 billion. In fact, Peter Galbraith, senator from Windham County, got hold of a piece of paper from somewhere in the administration that purported to have the leading plan for raising that $2 billion, something Shumlin has run away from at high velocity every time it's been brought up. Galbraith says, look for a 9% income tax on all income over $50,000, plus a gross receipts tax of 2% on every sale in the state, plus a 5% employer payroll tax. According to Galbraith, that would raise enough to pay the $2 billion tab. Shumlin denies all that, of course, and says we'll find out after he's safely reelected again. In short, single payer brings with it a host of difficulties that, if they can be solved anywhere, it would be remarkable. And if they can be solved in the state of Vermont, it would be beyond the bounds of imagination, given the talent we've got. Any doubt about the quality of our talent has just been dispelled by Vermont Health Connect's pathetic performance. But bear in mind, though, you don't want to work this argument too hard. Conceivably, somebody, like I heard Connecticut has done a good job, you can create a website that will do what they say. We didn't. But it could be done by somebody somewhere, Google or IBM or somebody. So it doesn't mean a single payer won't work, just because that particular website in Vermont didn't work. But I guarantee you a single payer won't work in a way that Americans will swallow. Because to make it work as promised, you've got to have conditions that cannot be achieved. Too many payers. And all the things that go with the budget, the global budget. So, unanswered questions: how to pay the $2 billion? How do you keep Vermont from becoming the shrine of Lourdes for the sickest people in America who come up here and debark from the bus and get a driver's license and a post office box and show up and get your card and get your treatment? What happens when you use up the global budget allocations? Will out-of-state hospitals accept cut-rate payment for Vermont patients compared to, say, New Hampshire patients? You think Dartmouth-Hitchcock can let somebody from Vermont be treated for X for $80 and charge the New Hampshire people $100 politically? I don't think so. And which hospitals will be closed? Well, I mentioned 4 that were highly likely candidates. Okay, resources, I've talked about that. Any questions I can answer in what little time I haven't eaten up?